I thought I should share with you some of the very important information that we have been teaching the other doctors and nursing teams, so that you are abreast with what is going on, and yeah, the changes we are trying to bring. So the title is Labeled Risk Assessment and Management. It was a workshop which we held on Tuesday. I think some of you were facilitating that workshop. But we did this workshop after noting that we are having a lot of fresh stillbirth and muscular stillbirth in our labor wards, even for babies who come with a fetal heart rate in labor ward, they end up as MSBs or FSBs, which was a situation which is of concern. So we thought probably hosting a workshop and training people how to monitor pregnancies, how to risk profile they may have. So we are very hopeful that if people put into practice what they were taught, we could see a change in practice. So these were the main intended outcomes of the workshops. We thought we were going to equip labor ward staff with skills for pregnant risk assessment, and to equip labor ward staff with skills to formulate a high risk pregnancy care pathway. One of the most important information which you should always carry in the back of your mind is why do women die? You should know what is it that is killing the women we look after the most. So you can see from our charts here that hemorrhage is the leading cause of why women die in our country. If we put it together with things like cesarean section and uterine rupture, probably these contribute almost a third, followed by conditions such as AIDS-related and eclampsia. But I believe from the latest data, AIDS should have greatly reduced because ARVs are working. Then we have conditions like infection, then malaria. They're still top in the list. And we have cardiac diseases. And of course, 7% die from unknown. So this is fairly old data. Then we do have why do babies die? So babies die because they are being born too early. And also the second thing is because they lack oxygen during the birth process. But from the fetal medicine point of view, I want you to understand that they do not lack oxygen during the birth process. They do lack oxygen starting in the uterus, most of the babies that you see. I will explain later. Then we have unexplained intrauterine fetal demise, which is very sad to say. You can't tell women why close to a fifth of them are losing babies. Then we have multiple pregnancy. You can see how important multiple pregnancy is and why we have to have a dedicated twins clinic where we standardize the management of the pregnant women, because they contribute 5% to the death of children, which is too much actually. And then we have infections, and then we have the others. I think I've shown you these two slides. So whenever women come to us, our goal is risk assessment. I think it's something that we would want everyone who is coming pregnant women to know that the most important task to do is not the history, is not the scan itself. The most important task to do is to be able to take a good, meaningful history, because that's where risk assessment starts. Being able to assess someone's risk is the most important task of any form of care that you can give to a woman. So we need to get this right, because as long as we think that performing the scan is our main task, then we are totally lost as a people. Our main task is to be able to risk assess a pregnant woman to see if she's at risk of these. One, preeclampsia, HIV, preterm birth, fetal growth restriction, major fetal defect, Down syndrome, Edwards and Patau, macrosomia, multiple pregnancy, and coexisting medical disorders, complications. What do we mean? I will take as an example. If you don't take history and you come to and you don't realize that the patient has lost 4 babies in a trot from preeclampsia. Secondly, you are going to do the most useless scan in the world because you are not going to measure the uterinatal Doppler. You are going to miss commencing this woman on aspirin and she had come in first trimester. You are going to miss to tell the pregnancy care plan, like she needs to check her blood pressure, she needs to come for growth assessment scans because you did not take a good history. If you miss that somebody's got HIV, she's going to go on in pregnancy. People are going to do a lot of things on her, and she might end up transmitting the HIV to the baby. If you miss through your history that the woman has lost 2 babies in a trot at 20-something weeks, definitely you are going to miss booking this woman. You will not check the cervix, first and foremost. You are going to do a scan where you don't bother to check the woman's cervix because you are totally disconnected from her story because you did not take a history. You did not risk profile the woman. So you will find yourself doing this kind of scan, which reports nothing about the cervix, or you will be those guys who are going to measure the cervix from the abdomen and not do a transvaginal assessment, a scan assessment of the cervix, because you are not aware of the pregnancy risk, the pregnancy you are scanning. In addition, you will end up not even booking this woman for a preterm surveillance clinic because you ignored or you overlooked how important the history is. Fetal growth restriction. If you don't ask carefully, and all you are saying that she is para 3, but you have forgotten to take note that this woman, the rest of the 3 babies were all 1.8 and 2 kilo babies at term. You are going to miss that this woman is at risk of having a small baby. Hence, she needs from the word go to be assessed in first trimester, to be assessed for the risk of preeclampsia, the risk of FGR, and the risk of, and be put on aspirin. In addition, you will miss bringing this woman for growth monitoring, and you will miss, optimization for delivery, and the woman will probably lose the baby this time around because the baby is not being monitored. Major fetal defect. If a woman has had a major fetal defect before, major fetal defects, I think we did the major fetal defect. You can reference our YouTube channel, Fetal Medicine Foundation Zimbabwe, where we covered fetal defects. We were always talking about recurrence risk. That if a woman has had a fetal defect, there are different recurrence risks for different defects. For example, if a woman has had a baby with a cardiac defect before, there is a 5% risk that she will have a baby with a cardiac defect in the current pregnancy she is having. But if you don't take a good history, you are going to miss that. And you will not refer the patient for a fetal echocardiography. Instead, you just do a normal scan and you report everything is normal. Yet probably the baby has got tetralogy of Fallot or has got transposition of great vessels because history was not taken properly for risk assessment. Down syndrome, Edwards and Patau. Once somebody is a Down syndrome baby, the risk of recurrence is about 1%. The same with the Edwards and Patau. But if you do miss this part of the history and you don't ask patients deep enough, and all you want to do is to cover the surface, you will miss again that this woman will need a screening at 12 weeks to make sure the baby she is currently carrying doesn't have Downs. And she may end up with having another Downs baby again. It's all to do with the history. It's all to do with the risk, pregnancy risk assessment. Macrosomia, very often missed. If you do miss that the patient is a baby with macrosomia, it's missed quite often, this issue. What do we do with macrosomia baby? If the babies were normal, then we want to screen these women for OGT, for diabetes. So an OGTT test should be done. But the thing is, if you don't take a good history, you are going to miss to screen this woman for diabetes in this current pregnancy, because diabetes is a silent disease. Pregnancy is another opportunity for us to pick this silent disease. This is why if you go to the physician wards, you find women with rotten legs there. You find women who are now turning blind. You find women who are now have permanent renal failure. We have had diabetes for years without even knowing that they have diabetes, because it's a silent disease, especially the type 2. So pregnancy is another opportunity for us to pick up women with diabetes so that they can get lifelong treatment and change their outcomes, long outcomes. So if you do miss that the previous baby with macrosomia, the whole scan which you are doing and the pregnancy care plan you are giving them is going to be totally haywire. Remember, fetal medicine is not sonography. It goes beyond sonography. It's pregnancy risk assessment. After pregnancy risk assessment, we give a care plan, an individualized care plan, which depends on the patient's risk, to say what is your risk in the pregnancy. Then we give a care plan which the obstetric team and the midwifery team are supposed to follow so that we have a successful pregnancy. So this is where the history assessment starts. Before the scan is done, we should know who is you. Multiple pregnancy complications, coexisting medical disorder. If you do miss that the woman has got epilepsy, the woman is chronic hypertension, is wrong pregnancy. If you miss that the woman has got thyroid diseases or has got diabetes, certainly you are going to be doing the wrong scans and give the wrong care plan. This is why we have to take the history always. There is no compromise. If you find yourself scanning a patient without taking history, without knowing them, then you are totally lost, because you are not understanding what you are trying to do, or you are not understanding what fetal medicine is. Because fetal medicine is not sonography, it's not about scanning them. People are already being scanned out there, but they are being done wrong scans. Why are they being done wrong scans? Because risk assessment is not being done by the person who is scanning. They do not bother to ask the patient, how are your pregnancies? Who are you? What disease do you have? What drugs are you taking? Nobody asks patients these questions wherever they are being scanned. As a result, wrong scans are being done. But that's not fetal medicine. Fetal medicine starts with the risk assessment. So that's the 11 to 13 weeks, or the first visit. So whenever a woman comes to you for the first visit, remember you have to take a good history so that you assess them for these kind of pregnancy complications. Well, this is what is affecting the pregnancies in our country, the top affections of pregnancy. This is what we have listed there. Then what about if a woman is in labor? What do we assess for? We assess for risk of failed labor. What do we mean by failed labor? If a woman comes to us and they've been given birth 2.5, 2.6 kgs, and currently a baby now is 3.8. Certainly, this woman we are saying probably she could be at risk of failed labor because her baby is big. But you can only know this information if you have taken a good history. If you haven't taken a good history, then you will not know it, and you will manage this labor as normal. You are not going to have a high risk index, a low threshold for intervention. That means you are more likely to watch this labor grinding itself to nowhere. rather than to intervene at the right time, because your risk profiling is not done. If a woman comes to you and tell you, look, doc, the last pregnant, they had to do me a vacuum and my baby was 2.7, or a forceps, whatever, interventional delivery. But this time around, your baby is 3.6. Certainly, you know you're more likely to have problems. And when you are watching this labor, you have to have a low threshold for intervention, rather than to ask them to continue to push and push and push until the labor becomes obstructed with the consequences of an obstructed labor. So history again comes to become important. When women come into labor, we assess them for the risk of postpartum hemorrhage. What is postpartum hemorrhage? Postpartum hemorrhage is bleeding too much at or after birth. It's defined as a cut of 500, but believe you me, it is always said to be relative. Any bleeding that causes hemodynamic imbalance, if a woman has an anemia of 8, even 300 mils may knock it down. So the issue is, you have to be able to identify these women before they deliver. If a woman comes to you with twins, you know they are more likely to deliver if they deliver naturally, even by Caesar, because this is an over-distended uterus. Women with polyhydramnios, they are more likely to deliver. Women who have prolonged labor, they are more likely to deliver. Why do you have to know this? So that you can prevent hemorrhage. How do you prevent hemorrhage? You make sure that you have your oxytocin infusion ready, you have your oxytocin bolus ready, you have your cytotec ready to insert as soon as the baby comes out, and you are there to massage the uterus until it contracts. And you are there to attend the tears and so forth. Puerperal sepsis. Who is likely to have puerperal sepsis? Women who have ruptured membranes, women with lower genital tract infection during the time of delivery. All these women need to be put on antibiotics. But it only happens if you realize that the woman is at risk. Birth asphyxia. Who is likely to be at birth asphyxia? All babies with placenta dysfunction. Babies who compress the labor, the umbilical cord in labor. So all babies with placenta dysfunction or placenta insufficiency are likely to be at risk of birth asphyxia. This is where you now come in as fetal medicine. As fetal medicine should be able to identify babies who are likely to have birth asphyxia, so that you can advise the labor and delivery team that, look, guys, this baby is likely to have birth asphyxia, either delivered by Caesar or tightly monitor the fetal heart rate, because you are saying the baby is at risk of lacking oxygen in the uterus. Neonatal sepsis. Who is likely to be at neonatal sepsis? Babies whose mothers have ruptured membranes. Babies whose mothers have got lower genital tract infections. Babies who are delivered after a prolonged labor, where so many VEs have been done. So what needs to happen? These babies need to be on antibiotics and be admitted in NICU for monitoring. Eclampsia. Who is at risk of eclampsia? Women who have gestational hypertension, women who have got preeclampsia, all these women are potential risk for feeding. Hence, they need to be given magnesium sulfate for prophylaxis. End organ damage. Who is at risk? Women with preeclampsia disease. They're at risk of this, so they need to be assessed. Risk of neonatal death, risk of congenital defects and syndromes. This is why it is important that no woman should go on to labor without a scan. This is why we have put some labor with scans in all our major hospitals. We put those labor room scans so that every baby can be given a minimum assessment when they come into labor and they do not have a prior scan. Some of you may say, why do I bother? Why should I bother scanning this woman? She's in labor. She's almost fully dilated. Believe you me, fetal defects, okay. You will see from the next presentation that we have lots of them, fetal defects. The baby could be having hydrocephalus with a head circumference of 50 centimeters, and you don't know it. And you are trying to force this 50-centimeter head through the vagina. It won't pass. The woman will sustain tears and labor goes nowhere. It's because you won't know that there is indeed a hydrocephalus there. You only know that there's hydrocephalus if you do a scan. The same way that you could be fighting a baby with anencephaly. You may be feeling the exposed brain like you are feeling some buzz, thinking that the woman is coming with the baby is coming with a breech. Yet it's an anencephaly baby. And you are busy monitoring and saying, guys, monitor quickly. And you are depriving patients who need closer monitoring because you are monitoring an anencephaly baby. So modern obstetrics and midwifery does not require this blind care of pregnant women where you nurse what you don't know. You don't even bother to say what is inside. So labor with ultrasound, very important. Perineal tears. So the question now is, how do we risk profile a pregnant woman? The most important part of risk profiling is the woman's history. There is no way you can manage clients properly without taking a good history. It doesn't matter who you are. It doesn't matter how many years you have been doing things. If you are not taking the proper history, you are more likely to do things wrongly. So take the good history, find the main complaint, find current pregnancy events, what is going on in this current pregnancy, find the past pregnancy events, what happened with the other pregnancies, the detail of it, not just say, how many children do you have? That's not good enough. Each pregnancy is to be asked in detail when the baby was delivered, how was it delivered, what was the birth weight, were there any problems during the delivery, and was there preeclampsia there, was there gestational diabetes, any other complication, was the baby admitted in NICU, did it come out as a low APGA baby? All that information has to be extracted from the past pregnancies. Was there any coexisting medical disorder in the past pregnancy? In the current pregnancy, does it have a coexisting medical disorder? What medical disorder are we talking of? We are talking of high blood pressure, we are talking of diabetes, we are talking of thyroid disease, we are talking of epilepsy, we are talking of women with cardiac diseases. All these have to be assessed for. Social habits, that include the medication that the patient is taking and their previous medical history, and that goes on to include their social issues in terms of where are they married, where do they come from, do they work, what's their level of education, all that affects their care. Do they smoke, do they drink, do they take marijuana, do they take other recreational drugs? Sorry guys, I think I lost you. So I want to come back into the meeting with the sharing device. I think the network dropped. So hopefully, let me come back now. Okay. Okay. All right. All right. So I will continue my presentation. So, okay, I'll leave a second device to check if I'm still in touch with you. So, right. Laboratory tests in maternal imaging. This is why we order laboratory tests. If a woman comes to you and you are suspecting that they have diabetes, you order the OGTT. If a woman has got polyhydramnios or poor growth, you order the torch to just make sure we're not missing something there. For women who come for Down syndrome, we don't just do Down syndrome with the scan. We also do the blood test. That's the complete way of screening somebody for doubts. Any other relevant maternal imaging. If a woman comes to us and she tells us she has got a cardiac disease, you want to see the fetal echo. Some may wonder and say, why do you want to see the fetal echo? Because if we find out that probably the aortic surface, the aortic area is less than 2, we are going to recommend that she be delivered around 2 weeks before she collapses. So every information matters. There's nothing like the tests that are done should be reviewed. Full blood count. If a woman has got an anemia of 6, certainly this woman is not going to be able to feed the baby. The baby will have FGR somewhere. So when you pick up FGR, you may wonder where it is coming from. It is coming from the fact that the woman has got severe anemia. But if you don't take the history, you're going to wonder why the baby is small. Believe you me, nobody else will know more about babies than you do now. So people will be looking at you to give them answers, to say, why is this baby small? Don't assume that the doctor on the other side who read the report knows what is going on. No, it's not like that. You know more about what is going on because you're the one who is looking after that, who is looking at the baby there. And this information is for you to use to give the right answers so that the clinical management of the patient is completed. Obstetrics and fetal ultrasound and CTG. I'm sorry that I think I have to correct. Let's correct now because I've been postponing correcting. I'll just come out of the slideshow a little bit. Let me correct this part, then reshade, which I think it's important that I put this here. Otherwise, people will not get, may think it's okay to forget it, but it's not. I'll reshare my screen just now. Right, so let me reshare my screen. Right, I think I should be back now. Right, there we go, sorry. Right, so I think it's coming. Oops, don't worry, the right one is coming. There we are. So obstetrics and fetal ultrasound examination in CTG. So the way I want you to understand issues here is scan is at the very end of your risk assessment. And it's not the most important thing here to do the scan. The scan has to be done, but I want you to understand that when it comes to pregnancy risk assessment, it's not the most important investigation you have to do, but it has to be done. As long as scan is not been done, risk assessment is not complete. it's incomplete pregnancy risk assessment. Why? The patient may pass all this, all of this, the patient may pass. But when you measure, when you assess the pregnancy, you find out that the patient has got very high uterine artery Dopplers with a very high PIs and with even the bilateral notching of the uterine arteries, whether it be in first or second trimester. All we are saying is that the patient is at risk of having early onset preeclampsia and is at risk of having FGR, placenta insufficiency, and FGR. But the woman will have passed the history, will have passed the physical examination, the initial laboratory test, but the woman will fail the risk assessment in the ultrasound. So this is why I want you to understand that if you do assess the woman with the history alone, because there are people who still believe scan is not important. These are the people I'm now addressing. That you can take a very good history, you can do a very nice physical examination and a nice laboratory test. Don't think you're done. You have not started in earnest, because after doing this, the baby you are nursing could have anencephaly, or could have holoprosencephaly. These are lethal conditions. Or could have body stroke anomaly. And you are busy reassuring this woman with your palpation that your baby is okay, the heartbeat is there. The presence of the heartbeat doesn't mean much, to be honest with you. It's reassuring to get it, but it doesn't tell you the physical well-being of the baby. The fact that the heartbeat is beating. All of us, our heartbeat will beat, even when our beat reading, we're not about that, our heart will be beating. The heart will only stop the moment we are dead for sure. So even babies who are about to die will have a heartbeat. Please get this right. Because there are people who use their peanut and say, how is my peanut, your baby is healthy. You cannot say the baby is healthy because you've put a peanut on the woman's tummy. More detailed assessment of the baby's well-being is needed before you tell the woman that your baby is okay because you've put a peanut and they've had a heartbeat there. Even people who are about to die, they'll have a heartbeat until they are dead. So please take this properly so that we know that ultrasound is very important. CTG. CTG comes in. Where does it come in? In babies, we have assessed ultrasound, and they've somehow not passed the ultrasound scan assessment. CTG comes to intervene in between the scans. Well, sometimes you assess a baby, probably a woman comes to you and tell you that, Chilemba, my baby is not moving as much as I would want. You do ultrasound, you do the Dopplers, everything is fine, but the woman is worried about the movements. How best can you reassure you? You bring her for CTGs. Then tell her, look, your heart is beating normally, there's normal variability there, there are good accelerations, and you reassure the woman. Then we have these babies who are monitoring probably every week. The CTG can work in between the week to monitor those babies. Where does the CTG come in? The CTG comes when you do a scan for a 42-week or for a woman with placenta insufficiency and FGR. Now you want to know, is it safe for me to go on and recommend induction of labor, or the woman will need a Caesar? A CTG will help us to actually categorize the level of chronic hypoxia that the baby is having, whether it is safe for you to for this baby to be induced or not. So that is where the CTG comes in. So again, let me emphasize this. For a high risk hospital like Parenyatwa, like Salimu Gabi, you cannot induce the high risk pregnant women without doing a pre-induction CTG and a pre-induction scan. It is unheard of in the world that there are people who are doing this, but I know this is happening. But this is why we are here, to change this. To say, guys, those terms are past. Those terms belong to medieval ages, whereby people are subjected to traumatic experience where you induce babies with chronic hypoxia and they come out as FSBs and MSBs. Those times are past. Babies should be assessed first. A CTG should be done. After they are done, then sure and certified that this baby can endure labor, then you can go on and induce. Now, let's go to the care pathways. If the woman is at high risk for PPH, what do we do? First of all, we look for the cause of over-distension. What is it? Is it due to over-distension or not? Because these are the cause of PPH. Do we suspect that the woman is going to have tears or the woman is going to have clotting issues? We need blood tests to answer some of these questions. The over-distension can be answered with an ultrasound. If you do an ultrasound, you can discover that there's polydramnios, there are twins there, or if a macrosomia baby. All these are potential cause of tears, especially the macrosomia baby. Then the clotting issues are done when you do full blood count and also the liver function test and so forth, and you look at the clotting profile. This happens in women who have had conditions such as placenta abruptio or who already have an inherent clotting disorder. Placenta position, how do you clarify it? The ultrasound. This is where we are coming to say you cannot risk assess without ultrasound. It is totally impossible. Placenta position, is it low lying? Do you have a previa? Do you have an accretor? Once you have this kind of situation, the management is very simple. There's no experiment here. You go on and do an elective seizure. If we are having a crater, which is probably bearing through and it's a crater, what do? An MDT has to be involved in the management. That means you need other disciplines to help. Because you may need urologists if you think the blood has invaded, or if you think the placenta is now going on and invading the intestines, you need general surgeons in theater. Over-distension due to this, we prevent PPH. For our central hospitals, we recommend what we call a doctor-supervised delivery. That means a doctor should be there so that they work against PPH, so that they prevent PPH instead of being called to manage the PPH. High-risk FGR. If the woman is at high risk of FGR, after doing your history, your risk assessment, because history assessment starts with a history. They are divided into two groups. There are those who are likely to have preeclampsia and those who are not likely to have preeclampsia. If the woman is likely to have preeclampsia from the preeclampsia risk assessment, they will need maternal BP monitoring daily. There is a register. I didn't put the register here, but probably I'm going to add it for the next training. So the woman is given a BP register to monitor at home. Let me make this very clear. The times are gone, and it doesn't work to ask the woman to come to the clinic every week for BP monitoring. That is not how BP is monitored. BP is monitored at home daily by the patient themselves. All you have to do is to encourage the patient to go and buy a $20 and $30 or $30 machine and monitor them at home. Let them know how important having this machine is for their health and that of the baby. Most women will go and buy it if you emphasize it enough to them. Because there are many things that cost $20, $30 that people are buying, that they can use the same amount of money to buy a BP machine for their own health and that of the baby. Women do understand they buy more expensive drugs than this machine if they really want to their baby and themselves to be well. So that's what we recommend. We do not recommend that the woman be told come every week for BP, because if the BP is high for the next 6 days, it will be ravaging the placenta. High blood pressures damage the placenta, and we do not want that to happen, because if you damage the placenta, the baby will not grow, and very soon the baby will be lacking oxygen in uterus. That's chronic hypoxia. Preeclampsia blood, fetal growth Doppler monitoring. There is no way you will monitor fetal growth without doing Dopplers for the high-risk group of women. Please don't do it. Because I know there are people who are monitoring growth without even doing Dopplers for the high-risk group of women. Then the no preeclampsia group, they need fetal growth monitoring. Then in terms of the management, how do we manage? If the Dopplers become abnormal and the preeclampsia is severe, delivery is penciled, as recommended by FMU. The FMU already has a protocol for managing FGR at different gestational age, so I didn't cover it here. This is a prerogative of FMU to decide when the baby comes out. So the FMU can decide, depending on the protocol that is existing. Then we have normal Dopplers. Preeclampsia is stable. There's then we have normal pre-induction CTG. Then these women can be induced as directed by FMU or CTG monitoring level with CTG monitoring level. We're talking of women who probably already have FGR, but this FGR is stable. That is fetal growth restriction. So that is the care pathway for the high-risk group. What about for women with diabetes? What does it look like, the care pathway? So we have the maternal indication. Sorry, let me close it. So for the diabetes, we have the maternal and the fetal monitoring issues. For women with diabetes, what do we need to do? We need to screen for end organ damage. We need them to monitor blood glucose at home using a register. How should diabetes be monitored in pregnancy? The woman has to do a fasting glucose in the morning and monitor it 2 hours later. Then they do every meal, main meal, that is lunch and dinner. How do they monitor? They monitor blood sugar 30 minutes before eating and 2 hours after eating. That is how blood sugar is monitored in pregnancy. What are the targets? To make it easy to remember, if you say 6 before eating and 7 after eating, those are the rough targets, but they can go as low as 5.8 and 6 point something. But we have seen that if women are able to maintain it below 6 and below 7 for after 2 hours after eating, in most cases, babies do well. But again, how is it monitored? It's not monitored at the clinic by the sisters at the clinic. The woman needs to be encouraged to buy a $30 worth blood sugar monitoring machine and monitor at home. That is the ideal thing to do daily at home. Sugar ends, monitor once a week or twice a week. No, it's monitored daily because any rise in blood sugar is potential to affect the baby. Then fetal screen for congenital anomalies, things like overgrowth. If the woman conceives with a very high blood sugar, with hyperglycemia, the baby is at risk of having congenital heart defects, things like endocardial cushion defects, the ASD, VSDs. So the congenital anomaly is a real threat. Then we need a fetal echocardiography, overgrowth, macrosomia. Babies overgrow when they are getting too much sugar. But with this overgrowing, because a hyperglycemia will cause what you call a hyperinsulinemia state, whereby the baby will start secreting too much insulin to counter the hyperglycemia. In doing that, insulin is an anabolic hormone that will cause overgrowth of tissues. It will cause most tissues, including the red blood cells, to multiply in large quantities and cause polycythemia. Polycythemia will mean that the blood will flow sluggishly within the baby. This sluggish flow of blood flow will result in some tissue level hypoxia on the baby, which may produce acidosis. And this is the acidosis that normally kills babies in diabetes. And we have heard the story of unexplained stool basic because of diabetes. These are some of the explanations of what happens with the diabetic babies. So please take note of this. Blood sugar has to be controlled. If not, then we may lose the baby. This is why we always ask for a register. Say, do we have the register? If anyone doesn't have the register in our unit right now, please get in touch with Thelma so that she can give you the register which you give to patients. Because we need patients to be given the register to monitor those with blood sugar. Then fetal echocardiography has to be done for these women. Then fetal growth and Doppler monitoring, then in FMO. Then what about this poor control of blood sugars here? And there's macrosomia. We deliver by C-section at 36 weeks. Why am I saying C-section? We have noted that these babies normally do not pass the pre-induction CTG. please do not induce before pre-induction CTG. Pre-induction CTG is vital here because without a pre-induction CTG, you will have an FSB. I hope I'm making it clear because we see these babies, even in the private sector, we always put on them on CTG when they come to us and they fail the CTG test. So we recommend them to be delivered by C-section. The babies whose mother's blood sugars are poorly controlled. Good control at 38 weeks, pre-induction assessment pass. That is, you have done a pre-induction CTG, then we can then, and the weight is less than 4 kgs, then we can induce. But this is a doctor supervised delivery because of the risk of shoulder distortion. Then normal fetus, we follow the above. Congenital defects, we follow the FMU recommendation if the baby has a congenital defect, because sometimes we find babies who already have congenital defect from poorly controlled diabetes. Then there is a fetal defect care plan, which is followed. Then FGR, then in that case, we follow the FMU recommendation for FGR. Some may wonder, why do diabetic babies end up with FGR? They end up with FGR because for women who have had diabetes for years without it being missed, they end up suffering from vasculopathies. The vasculopathies cause poor placentation, and this poor planted placenta will result in the baby who is not feeding well, and these babies will end up with FGR. So remember this, that the majority of diabetic babies are actually AGA. Then we have about 10% of them will be SGA, and then probably 15% of them will be LGA among the diabetic cohort. Sometimes they are SGA because because of the vasculopathies, that the woman has a certain degree of vasculopathies that doesn't allow them allow the baby to get all the glucose that is presenting at the uteroplacenta interface. So a normal grown baby in a diabetic woman is not a sign of good control without you checking the register. So remember, the register has to be checked, irrespective of whether the baby is growing well or not. Because if the placenta is damaged, it will not make the baby overgrow, even if the sugar is a bit. But if the placenta is good, the baby will overgrow. So the overgrowth of the baby is a sign that that placenta is working, and it's also a sign that the sugars are poorly controlled. Right. So let me proceed. Right. Is that all? Okay. I think that is all. Why do we risk profile? So that we know the antenatal care pathway. We know when to deliver, the delivery timing. We know where they should deliver, the delivery place, and we know how they should be delivered, so that we know how they should be delivered in terms of the delivery mode. And we also know the level of the health personnel who should conduct the delivery and the immediate postpartum care. Okay, I think this presentation ends here. Before I call it quits here, give me a second. I want to share something with you briefly, maybe for 2 minutes. Just give me a second. I want to re-explain something which you explained, because I think people are now more ready to receive this certain kind of information than they were before. So I want to reshare this information. Give me a second, guys. We'll be done just now so that people can go on with their day. Let me see. Give me a second. Right, so I think I'm ready. Let me Share, new share. Right, I think you have the slide with you there. I want to explain something to do with chronic hypoxia. So, how does chronic hypoxia work? And how can we improve our detection of chronic hypoxia as we scan the babies? So, how it works is that the progressive reduction in fetal oxygen due to the placenta insufficiency will result in the release of catecholamines. The catecholamines are adrenaline and noradrenaline. And these catecholamines will increase the fetus baseline heart rate. And these are the ones that also respond for the redistribution. I think redistribution, you are familiar with it now. We have seen lots and lots of redistribution patterns on the middle cerebral artery. So whenever you see the redistribution, know that the baby is at this stage or is past this stage here. These are babies who are suffering from chronic oxygen deficiency and who are now operating more in what we call a compensated mode. They're trying to compensate for the lack of oxygen by increasing their fetal baseline heart rate. And this you will see when you do the CTG that the baseline heart rate is greater for gestational age. And the redistribution, you are going to see it with the ultrasound when you do the MCA Doppler. This is why we are saying MCA and CTG, ultrasound and CTG cannot be separated when it comes to assessment of the high-risk group of women. The reduction in fetal growth, unfortunately, is metabolic adaptation, which is another very big issue. This metabolic adaptation, which is due to epigenetics, is what will lead to all the lifestyle diseases that we know, from Parkinson, Alzheimer, to the metabolic syndromes later in life, because the genes have been modified to work with less. What you feed them as babies is sufficient, is too much for them. So they overgrow and be fed and suffer from the obesity and all kinds of things. But let's continue this journey. So now, if they show evidence of compensation, if we don't do nothing here, don't do nothing, you just continue monitoring these babies as normal, and you are not closely watching them, the baby is going to progress to fetal decompensation. What are the features of fetal decompensation? What you are going to see is, because of the acidosis which is now building, there are going to be shallow decelerations. There's going to be loss of variability, baseline variability, and we are going to see something called cerebral decompensation. Cerebral decompensation, what happens in cerebral decompensation? We are going to see an increase in the MCA-PR. Instead of decrease, the MCA-PI will now increase. I think we've seen it in babies who are about to die with scan. Those babies who have reversed airwave in the ductus venosus, they now have cardiac failure. When you check their MCA is either normal or a very high PR. Then there will be myocardial decompensation, which is a progressive reduction in baseline fetal heart rate. Some of you have scanned babies like this. Because I remember people coming to me and say, Dr. Verenga, we've scanned the baby next door who has been referred to us. The heart rate is now 70 or 80 beats per minute. The baby is now in this phase here. There is now myocardial decompensation, whereby the heart is now being poisoned by the acidosis and cannot maintain the beating. If you do a CTG, you're going to see a step ladder deceleration to death. So as fetal medicine, what should we do? As fetal medicine, this is where we should pick up babies at this level here and recommend a care plan. We should never allow babies to go here, because once they are here, they're intractable. To bring them back is extremely difficult, more so with our incapacitated NICU. To be honest, most of these babies will lose them. They all don't make it the moment they are in this phase. So your task is to make sure we intervene when babies are still at this stage. Doing a CTG after seeing that the baby is showing redistribution, more for 10 babies, is worth it. Do a CTG so that you don't send this baby away unnecessarily. Because if you send them away, they'll come back in a worse situation and they will not make it. We have too many FSBs and MSBs in our labor ward. But as fetal medicine, we can help to recommend the right intervention time so that we don't recommend intervention when we're already here, because no one can save these ones, to be honest. So yeah, I think that's my last slide. Thank you so much. The other presentation probably will be for another time. But thank you so much. And questions we have. Questions can be typed in the group. If you can speak, if you can't type, you can always post in the WhatsApp group as well. But because of time, I think I'm going to end the meeting.